This is JAPI, and welcome to JAPI Podcasts.
I am Dr. Atul Bhasin. Welcome to the JAPI podcast of the February 2025 issue of JAPI, Volume 73, Issue 2. This issue of JAPI has some really interesting articles, including 8 original articles, 2 review articles, 1 point of view, 6 unique case reports, 3 pictorial CMEs, and 1 letter of correspondence. Let's discuss these in detail. The first original article is titled Urinary levels of neutrophil gelatinase associated lipocalin and cystatin C in patients with hepatitis B on tenofovir treatment. This was written by Shivani Rani et al. Tenofovir disoproxil fumarate is a first-line treatment for chronic hepatitis B virus. While effective TDF is also associated with nephrotoxicity, which can occur through various mechanisms, including mitochondrial DNA depletion and damage to renal tubules. The nephrotoxic effect may lead to acute kidney injury, demonstrated by elevated serum creatinine and reduced serum phosphate, which are often very late to rise. Any other way of predicting early nephrotoxicity of tenofovir may help in better management of chronic hepatitis B. Biomarkers like urinary neutrophil gelatinase associated lipocalin, that is NGAL, and cystatin C have already been identified as independent early predictors of AKI. The primary objective of this study was to investigate the levels of urinary neutrophil gelatinase associated lipocalin and cystatin C as early biomarkers for AKI in hepatitis B virus patients with TDF therapy. 350 cases were screened, out of which 226 cases were eligible after detailed assessment. The results showed the average age of participants was 37.937 years, with the majority in the 18 to 35 year age group. 87 cases, that is 38.4%, showed elevated levels of NGL and cystatin C, predominantly in younger groups and males. This showed that elevated levels of NaGL and cystatin C indicate potential early kidney dysfunction in hepatitis B virus patients on TDF. It also suggests need for further prospective studies to better understand TDF's impact on kidney function. To conclude, the TDF treatment is linked to increased urinary NGL and cystatin C, suggesting early nephrotoxicity. Regular monitoring of kidney function is recommended for hepatitis B virus patients on TDF therapy. The authors also recommended regular kidney function tests, including urine protein and serum creatinine, for patients on TDF. Consider adjustments in TDF dosage or switch to another antiviral if kidney damage is detected. The next original article is titled Impact of Blood Glucose Level on Hematological Indices in Patients with Type 2 Diabetes Mellitus. This was written by Dr. C.L. Nawal et al. This study was conducted on 300 patients with Type 2 Diabetes Mellitus, which included Group A having controlled diabetes, that is HbA1c of less than 7, and Group B having uncontrolled diabetes, that is HbA1c greater than 7. Information concerning medical history, physical examination, diabetic parameters and hematological indices and laboratory findings was extracted from interpretation and association between both the groups. The results showed there were about 115 patients, that is 38.33% patients, who had an HbA1c of less than 7%, and another 185 patients, which was 61.67%, had HbA1c more than 7%. The total leukocyte counts, monocytes, basophils, red cell distribution with RWD-CV, platelet distribution with PWD, mean platelet volume, platelet large cell ratio, platelet cret, neutrophilic to lymphocyte ratio, and platelet to lymphocyte ratio were significantly higher among patients with uncontrolled type 2 diabetes mellitus compared to those with controlled type 2 diabetes mellitus. P-value was 0.05. While RBCs count hemoglobin, mean cellular volume, and mean corpuscular hemoglobin were significantly lower in the uncontrolled diabetic group compared to the controlled diabetic group. HbA1c had a significant positive correlation coefficient with TLC, neutrophil count, basophil count, PWW, LPD, PCT, PLR, and NLR, while RBC count, hemoglobin, hematocrit, and MCV showed significant negative correlation coefficients. To conclude, this study concluded that the inflammation, tendency to coagulation, and thrombosis can be detected with easily accessible and inexpensive hematological indices. Therefore, hematological indices can be used as a direct measure to detect the severity of type 2 diabetes mellitus and its complication. The next original article is on acute kidney injury. This is on clinical profile, prognosis, and outcome of acute kidney injury patients admitted in medical intensive care unit. The article was written by Dr. Devendra Bhushan et al. Acute kidney injury is one of the poor prognosticating conditions in the intensive care units. It increases mortality. Its pathophysiology involves various aspects such as prerenal, renal, and postrenal components. Many times, it's a combination of one or more etiologies. Its management is a challenge as no agent is approved for its prevention or treatment. It is the comprehensive treatment and timely institution of renal replacement therapy that matter most. To understand the prognosis outcome of patients with AKI, we conducted this study. Out of 77 patients who were recruited, of these, 5 patients were excluded because they were found to have a chronic kidney disease. The mean age of patients who was 55.3 plus minus 16.2 years. 54.2% of them are males. Mean length of stay was 12.58 plus minus 7.63 days in the ICU. Comorbidities like hypertension, diabetes, coronary artery disease, cerebrovascular accident, infection, malignancy, chronic obstructive pulmonary disease were present in 33.3% patients or less of patients respectively. About 44.1% of patients had diuretics used during their course of treatment. 66.7% of patients were oliguric or anuric at the time of presentation. 68.1% of patients expired during the course of their treatment. There was no clinically significant difference in mean SOFA score, Apache 2 score, and total length of stay. There was no significant difference in the need for renal replacement therapy and the need for vasopressors between the two groups. When we compared the outcome between these two groups, it was poorer in the group that received diuretics. To conclude, the use of diuretics did not improve the outcome of acute kidney injury. The next is an interesting study. The effect of clinical decision support tools on physicians' practices. This is by Dr. Amreen Faqih. Study is focused on assessing the impact of clinical decision support tools on the practices of Indian physicians. CDS tools are software applications designed to assist clinicians by providing evidence-based recommendations or assessments tailored to a patient's specific characteristics. This research aims to evaluate how these tools influence medical decision-making, diagnostic accuracy, and the reduction of unnecessary tests among physicians in India. The study utilized descriptive statistics and frequency distributions to assess the data. Physicians were surveyed through a primary survey conducted via social media platforms, and the response were analyzed to determine how often CDS tools were used and their impact on clinical decision-making. The results revealed that approximately 69% of the physicians surveyed frequently use clinical decision tools in their practice. A notable, that is 54% of the sample, indicated that CDS tools influence 1 to 5 decisions each week, showcasing a moderate yet consistent integration of technology into their daily routines. However, a significant proportion of sample, that is 31%, reported that they rarely use the tools with no noticeable impact on their decision. In terms of diagnostic accuracy, 46% of doctors reported making zero errors in the decision-making after using this application. whereas 54% acknowledged making errors in 1 to 5 decisions weekly, signaling that while the tools improve diagnosis, they do not fulfill or do not fully address all the physician's needs. Despite these improvements, the CDS tool did not significantly reduce the number of diagnostic tests ordered. While many doctors indicated ordering fewer than 5 tests post implementation, others continued to order over 10 tests, possibly due to skepticism about the technology or limitations within the sample size. Additionally, the study explored the cost effectiveness of these tools and found that not all CDS tools were cost effective. The variations in cost effectiveness can be attributed to differences in the comprehensiveness of information, product features, and healthcare practices in which these tools are used. To conclude, the findings from this study highlight a key observation. There is a lack of full trust in technology, especially among older physicians. However, younger doctors appear to be more open to adopting and using these tools in their private practices. Overall, doctors agreed that CDS tools provide quicker diagnosis and are generally user-friendly. Despite the positive feedback on these benefits, the studies indicate that the CDS tools still have room for improvement in terms of reliability, cost effectiveness, and a broader integration into clinical practice. In conclusion, while CDS tools offer valuable support in improving decision making, they are not yet universally adopted or optimized, particularly among older practitioners. Further studies are needed to assess the long term impact of these tools on patient outcomes and healthcare costs. Our next study is titled Evaluation of Relationship Between Procalcitonin and the Total Leukocyte Count, Neutrophil, and Neutrophilic oblique lymphocyte ratio in patients with systemic inflammatory response syndrome and sepsis, which was a hospital-based study. This was conducted by Dr. Om Prakash Dhakal et al. The objective of this study was to ascertain correlation between procalcitonin and TLC neutrophil count NLR in patients with SARS with or without infection, sepsis, and to evaluate TLC neutrophil count and NLR ratios between SARS without infection and sepsis. Acutely ill patients aged 18 years or older who fulfilled the criteria for SARS were included in this study. The serum PCT, TLC, blood culture were done within 12 hours of admission. Out of 282 patients with SARS, 194 patients had no documented infection, that is group 1, whereas 88 patients had documented infection, that was sepsis group 2. The difference in age, sex between both the groups was found to be statistically significant. All 4 markers, that is PCT, TLC, neutrophils, and NLR, were significantly higher in the sepsis group. So, to conclude, this study said that the PCT is the best marker to predict sepsis, and it correlated significantly with TLC, neutrophil count, and NLR in SARS without infection, and with neutrophil count and NLR in sepsis. Secondly, TLC and NLR are also good predictors of sepsis and can diagnose sepsis in resource-poor settings. The next article is on estimation of predictors of mortality in patients with acute respiratory failure secondary to chronic obstructive pulmonary disease admitted in tertiary care center. This article was published by Dr. Hardik Jain et al. A hospital-based prospective research observational study was conducted in a tertiary care center to assess how well D-dimer, CRP, Apache 2 score, and hypoalbuminemia predict death in COPD with acute respiratory failure. Results showed that the median D-dimer levels for patients who lived and died were 1012.34 and 7222.64 respectively, with a p-value less than 0.001. Patients who survived had a mean CRP of 3.56, whereas those who were dead had a value of 12.62. The mean serum albumin levels among the survived and the dead patients was 3.23 and 2.22 respectively. The mean Apache 2 score in survived and dead patients were 9.91 and 28.48 respectively. The Apache 2 score has sensitivity and specificity of 96 and 91.4% respectively, with a critical cutoff greater than 90. Hypoalbuminemia has a sensitivity and specificity of 96 and 65.7% with critical cutoffs of less than 3. To conclude, it showed that the high levels of CRP and elevated Apache 2 score, elevated levels of D-dimer, and lower levels of serum albumin are all independent related to an increased risk of in-hospital mortality. The next original article is on insulins. It is on safety and efficacy of biosimilar insulin glargine, Basal-Glar, in Indian patients with type 2 diabetes mellitus. Results from a multi-center, open-label, single-arm, phase 4 trial ABEX. This was conducted by Dr. Bansi Sabu and et al. This was a phase 4 multi-center, open-label, single-arm trial that was designed to evaluate the safety and efficacy of Basal-Glar in Indian patients with type 2 diabetes mellitus. It included participants from 18 to 75 years of age with type 2 diabetes and had at least 6 months of HbA1c of more than 7% to less than 11%. The study had 2-week screening and 24-week phases with safety follow-up at 28 weeks. The treatment phase included a titration phase from 0 to 12 weeks and a maintenance phase from 12 weeks to 24 weeks. Among the 304 patients enrolled, 259 eligible patients were treated with least one dose of Basal-Glar and 218 patients completed the study. Most patients were males, that is 61.4%, with mean age of 52.1% and a mean BMI of 26.7%. The mean baseline level of HbA1c was 9.03 and approximately 64% of patients had an HbA1c levels of greater than 8.5%. The mean duration of diabetes was 6.75 years. More than 25% received at least 2 concomitant anti-hyperglycemic medicines with oral basal BG lowering and drug combinations. That was around 53.757%. Biguanimides 46.7%. Sulfonylureas 42.1%. DPP-4 inhibitors 40.2%. And alpha-glucosidase inhibitors 33.2%, being the most common. Metformin, that was 98.1%, and sulfonylurea, that was 89.2%, and DPP-4 inhibitors, 55.2%, were the most commonly used concomitant anti-hyperglycemic medications. The most common reported comorbidity in medical history was hypertension, that was 44%, and dyslipidemia, that was around 17.4%. Incidence of total hypoglycemic events and other adverse reactions, the incidence of total hypoglycemic events were around 10, that is 3.86%, 7%, and 4% during 0 to 24 weeks, 0 to 12 weeks, and 12 to 24 weeks respectively, without any severe hypoglycemia. AEs were reported in 3.9 cases out of 12 AEs. 11 were mild to moderate and were not severe. None of the reported AEs were considered treatment-related or led to treatment discontinuation. Subjects reaching HbA1c target of less than 6.75% or less than 7% and a change in fasting blood glucose levels from baseline were at 12 weeks, 6.9% and 15.1% of patients achieved HbA1c of less than 6.5% and less than 7% respectively. At week 24, 15.1 and 23.6% of the patients were reported to have achieved an HbA1c of less than 6.5 and less than 7% respectively. The change from the baseline was significant. That was p-value was less than 0.0001 at all the visits. The mean change of fasting blood glucose was minus 20.6, minus 3.52, minus 37.6, and minus 42.5 from the baselines at the weeks 4, 8, 12, and 24 respectively. So to conclude, the Indian patients in the ABEX trial showed that Basal-Glar was well tolerated with few hypoglycemic events. Vesaglar, when combined with GLP-1 RA or at least two OAMs, significantly reduced HbA1c and blood glucose levels from baseline in patients with type 2 diabetes mellitus. The safety and efficacy profile of Besaglar in the phase 4 ABEX trial was consistent with that reported in previous phase 3 trials, Element 2 and Element 5. The last original article is titled Hospital-Acquired Infections in Adult Intensive Care Unit, Epidemiology, Resistant Patterns, and Risk Factors. The authors of this article are Kapil Gangadhar Zirpe and al. Hospital-acquired infections are defined as infections that develop in the patient after being admitted to the hospital. The overall burden of HAIs is known to be higher in developing countries. The most common HAIs include ventilator-associated pneumonias, catheter-associated urinary tract infection, COTI, surgical site infection, that is SSI, catheter-related bloodstream infection, that is CRBSI. The aim of the study was to evaluate the incidence rates and causative organisms of intensive care unit acquired with infections at a tertiary care center to determine factors associated with mortality in patients with ICU-acquired infections. It was a single-center, prospective, observational study. The incidence rate in current study revealed that VAP incidence was 105 upon 206.81, that was 39.1 per 1,000 ventilator days. CRBSI incidence was 38 upon 4,871, that was around 7.8 per 1,000 central venous catheter days. And COTI incidence was 54 upon 11,201, that is 4.8 per 1,000 urinary catheter days. Acinetobacter baumannii accounted for 41% of infections in patients with VAP and 21% patients with CRBSI. E. coli was the most common causative organism in the COTI group, accounting for 33% of the infections. Age more than 50 years, presence of hypertension or presentation, medical diagnosis, multiple ICU-acquired infections, and a higher Apache score on admission are the statistically significant determinants of the incidence of mortality in the overall group, with a p-value of greater than 0.05 for all. To conclude, this study showed that the age more than 50 years, presence of hypotension on presentation, medical diagnosis, multiple ICU-acquired infections, and higher Apache score on admission must be kept in mind as determinants of incidence of mortality in hospital-acquired infections. The next article is a review article, the first review article of today's podcast. It is on biomarkers of gestational diabetes mellitus, mechanisms, advances, and clinical utility. It is by Dr. Thai Parimbil Arvadarshkishan et al. Gestational diabetes mellitus affects about 13% of pregnancies worldwide and is associated with significant maternal and fetal risks, including preeclampsia, fetal macrosomia, and long-term health issues such as type 2 diabetes mellitus in mothers and children. The prevalence of GDM varies by region, with 15 to 18% in India, highlighting a growing public health concern. Early identification and management are critical to improve health outcomes. The review emphasizes that a multifaceted approach integrating biomarkers could lead to significant advancements in GDM diagnosis, management, and long-term health outcomes for affected women and their children. This view categorizes biomarkers into several key groups. That is, number 1, glucose metabolism markers, that is fasting plasma glucose, a central marker for GDM diagnosis with varying threshold levels debated for optimal risk prediction. Oral GTT, the gold standard, though time-consuming and associated with patient discomfort. Glycated hemoglobin HbA1c, that is explored for prognosis and identifying women at risk of complications but not typically used for early diagnosis. Insulin sensitivity and secretion markers, that is HOMA-IR, which measures insulin resistance, which is elevated in GDM, indicating impaired insulin signaling. Insulin and C-peptide levels, These are elevated levels which reflect a compensatory response to insulin resistance, but in late pregnancy, C-peptide may rise disproportionately, indicating beta cell stress. Then are the inflammatory markers, that is CRP, pro-inflammatory cytokines like TNF and IL-6, and these indicate inflammation, a key feature of GDM, which also contributes to insulin resistance, increasing the risk of complications. The others are adipokines, leptin, adiponectin, and nesfatin. There are other oxidative stress markers, that is aldehyde, that is MDA, and F2 isoprostanase, which are elevated in GDM. There are urinary markers like L-tryptophan and ceramides, and placenta-derived markers like follistatin like 3, PIGF, and fetuin A. There are some emerging biomarkers in gestational diabetes, and these are genetic and epigenetic markers. These variants in genes like TCF7L2 and PPARG have been associated with insulin resistance in GDM. Epigenetic modifications, that is DNA methylation, also play a role and may affect both maternal and offspring health, potentially increasing the risk of metabolic diseases later in life. MicroRNAs, that is small non-coding RNAs such as MIR29A and MIR222, influence insulin signaling and inflammation. These miRNAs are emerging as potential biomarkers for GDM. There are metabolomics, which are altered metabolite profiles, that is elevated branch-chain amino acids and ceramides. There are proteomics, which are protein dysregulations, particularly in protein involved in insulin signaling, inflammation, and oxidative stress. These offer an insight into GDM pathophysiology. Changes in placental proteins also highlight the impact of GDM on placental function and fetal development. Microbiome, that is gut microbiota changes, contribute to inflammation and insulin resistance, and microbial profiles may serve as early predictors of GDM, offering opportunities for early intervention. What are the clinical implications of these biomarkers? These biomarkers are crucial for improving early detection, offering the potential to tailor interventions for high-risk women before the development of full-blown GDM. Incorporating emerging biomarkers into routine screening could reduce reliance on cumbersome tests like OGTT, improving patient management and reducing complications. Personalized approaches based on biomarkers could also help monitor the transition of type 2 diabetes post-pregnancy, ensuring long-term health for both mother and child. Further research is needed to validate these biomarkers and integrate them into predictive models that combine genetic, epigenetic, metabolic, and inflammatory data. Our next review article, and the last one for today, is Association of Physicians of India Consensus Recommendations for Vonoprazan in Management of Acid Peptic Disease. The author is Dr. Rajesh Upadhyay and et al. The suppression of gastric acid secretion is the cornerstone of treatment for acid peptic disorders. Use of proton pump inhibitors have been central in managing these conditions. Vonoprazan is a first-in-class potassium competitive acid blocker, that is PCAB, has been used in clinical trials, and extensive clinical evidence suggests that vonoprazan offers more potent acid suppression than the PPIs. This consensus from API has been developed for the appropriate clinic usage of vonoprazan. An expert panel with multidisciplinary consensus working group was formulated by the lead expert from the API. A total of 13 statements were initially framed for presentation in the consensus working group meeting. Utilizing the Delphi method, a consensus was formulated. So what was the consensus? Consensus number 1 was that there is a substantial presence of acid peptic disease in India. Number 2, currently available PPIs have certain limitations in management of gastroesophageal reflux disease. Number 3, majority of GERD patients on PPI do not comply with the advice of taking PPIs at least 30 to 45 minutes before meal, leading to a diminished treatment effectiveness and or increased treatment failures. Number 4. Vonoprazan potentially overcomes the clinical relevant limitations of PPIs as it can be administered irrespective of the meal timing. It may be considered as an alternative treatment approach to the PPIs. Number 5. The refractory GERD patients switching from PPIs to vonoprazan, that is 20 mg once daily, is considered as the most suitable treatment approach. Number 6. It reduces the treatment duration by 4 weeks. Number 7. Vonoprazan is recommended as the initial treatment approach for the severe EE, that is LA grades C and D. Number 8. Vonoprazan may be considered as an alternative to PPIs in the treatment of NERD with excessive esophageal acid exposure, and in long-term management, it may be considered as an on-demand treatment approach. Number 9. The eradication regime for H. pylori infection, vonoprazan is recommended in place of PPIs. Number 10. Vonoprazan can be an alternative to PPIs as a concomitant therapy in patients with high risk of peptic ulcer disease with chronic use of NSAIDs. Number 11. It can be considered as an alternative to PPI in the treatment of LPRD. Number 12. In the metering therapy of gastroesophageal reflux disease, it is found to be safe. In patients with cardiovascular myopathy receiving antiplatelet therapy, it can be considered as a treatment option with careful monitoring. Number 30. It can be considered in patients with renal and hepatic impairment with careful monitoring. To conclude, the unique action of vonoprazan inhibiting active and inactive proton pumps at gastric parietal cell provides effective acid suppression. It holds a promise to be a frontline therapy in APD management. With a comparable safety profile to those of PPIs and better efficacy, it has emerged as an excellent alternative to PPIs in mild to severe forms of APD. Its appropriate use will help in achieving maximum therapeutic benefits in the acid peptic disease. With this, I finish this podcast of JAPI and best wishes to all of you. Thank you for listening to the JAPI podcast. Jai Hind.